Hi. Hi everyone, my name is Therese Lloyd and I'm part of the Improvement Analytics Unit, which is a partnership between the Health Foundation and NHS England. And on behalf of the Nuffield Trust and the Health Foundation, I'd like to welcome you all to the 2024 Rapid Evaluation in Healthcare Conference. We're delighted to have you all here. Thank you especially to those of you who have braved the train strikes and disruption to make it here in person. I know that there are several of the speakers and chairs who've made changes to their plans to accommodate the train strike, so a special thank you to you. This year's theme is evidence-based decisions when budgets are tight, rapid evaluation and knowledge mobilisation. And as you know, the UK health and social care system is under considerable pressure with increasingly tight budgets. And today we'll be exploring what that means for evaluation and how we can try to support the system to make better evidence-based decisions. Part of that will be exploring ways to mobilize knowledge, so ways to access existing evidence, assess whether evidence is robust and reliable, and also ensure that it leads to rapid change. And knowledge mobilization was actually a theme that came out of last year's conference in the discussions, not only in the panel discussion, but actually in some of the questions that were asked during questions and answers after other sessions, and as part of other discussions throughout the day. So thank you for contributing to creating today's conference, and please continue to do so. Which brings me on nicely to another aim of this conference, which is to bring together people from different sides of evaluation. So not only evaluators, but also decision makers, implementers, enablers and implementers of change, service users, decision makers, etc. And we hope that today will be an opportunity to connect with people that you don't already know and to share ideas and perspectives. And to that end, there are plenty of breaks and networking opportunities throughout the day. We'll be starting shortly with our first plenary, then there will be the first of many breaks. Then we will have 3 different breakout sessions to choose between, and please do look in your programs to choose which one you'd like to go to. For those of you who are finding it difficult to choose between the different sessions, all of them will be recorded and available after the conference. Then there will be lunch, then there will be another 3 breakout sessions to choose from, and then we'll finish off with the last plenary back in this room, and we'll be finishing the day at about 4:30. Please do use the hashtag Rapid Evaluation to share thoughts and continue any conversations on social media. And then I just got a couple of quick housekeeping things. If the fire alarm sounds, it is not a test, and please leave the building via the nearest exit as soon as you can. Please do put your phones on silent. And lastly, it's a beautiful day today, and we can actually use the courtyard, so please do feel free to go out into the courtyard during the breaks and lunch. And I hope you enjoy the day. I will now pass on to Judith Smith from the University of Birmingham, who will be chairing the first session. Thank you.
Well, good morning, and it's great to be here and introducing this first plenary session, which I really intend will be interactive and an opportunity for us to just start to, I guess, get our thoughts going, think about the challenges and opportunities of rapid evaluation in these often tough times for health and social care. Now, in this first session, I've got 4 expert speakers who will be offering their perspective on rapid evaluation amidst the current challenges. And then I'll be facilitating a discussion, so do note your questions as they're talking. We will take each of them and then move into the rest of the time as an overall discussion. So this session's about thinking about rapid evaluation, how we build and critically, as Therese was saying, use evidence to feed into policy making, but day-to-day management and clinical service practice. And just as a way to get us thinking about this morning, I was reading again some work that two of the National Institute of Health and Care Research funded rapid evaluation teams, the first two, which was the Brace Centre team, led by the University of Birmingham, and the RESET team, which is led by UCL and also involving the Nuffield Trust. We, about 18 months ago, published what we called an essay. It's like a report of our reflections on rapid evaluation and particularly the practice of it, how to do it, how to use it, and how to skill people up, to do and use rapid evaluation. And in that piece of work, which is available on the Brace, the RESET, the NIHR websites, we used as the framing of that some work by some academics, Riley and colleagues, from a number of years ago. And the four terms, well, there were three in the original Riley work, but we added one. They all begin with R. So you've got rapidity, unsurprisingly, then responsiveness, then relevance, and rigour. Rigour's the one we added, actually, in our when we were doing our overall reflections of our 5 years of rapid evaluation work. And for me, these kind of encapsulate, I think, the what, the why, and the how of rapid evaluation. So the what, are we responding to an actual need? A why, is this relevant as an approach? Is it relevant to actually use rapid evaluation? And then how, is it properly rigorous, or as rigorous as is practically possible? So I hope perhaps just having that sense of responsiveness, relevance, and rigour might just be a helpful framework or set of terms to have in your mind as we start our thinking today. So that's just some thoughts to get us going. So I think that's sufficient from me just to set the context for the discussions. And I'm going to invite, first of all, Thea Stein, the Chief Executive of the Nuffield Trust, to offer her thoughts. And she's, I think, particularly going to focus on some of the policy and productivity challenges that are facing our services at the moment. Over to you, Thea.
Thank you. I'm never sure with lecterns whether or not I'm going to be seen over them, but I think it's working, or I can stand here, which will be fine. So I just wanted to have a few reflections about the context in which we are all working today, because they are particular and they are quite febrile. And that noise and that context actually speaks to everything that we do, and it should do. We don't work in a bubble. We don't exist outside of that world. And the first of the big contexts is, of course, this will be an election year. And that will shape what is commissioned and what is heard. Because what we do and how we create research is within an environment in which we want it to be heard. And when we are creating a product in a situation in which there is an election, there is a lot of noise, and that's really important. What's the framing conversation for politicians at the moment? Well, I think it's a very simple one, and it's one of our breakout sessions, and that's the productivity question. You don't go into a room with any politician who doesn't want to talk to you about productivity, by which they mean a very simple algorithm, the view there is more money, there is more staff, and there are fewer outputs. Now, we could spend the rest of the day debating what that statement really means and all of the issues around that, but that is a framing context within which all thinking is currently taking place for politicians. I don't think that is the framing context for the public, and I think it's really important to understand where the public will be coming from, because that will also intersect with where politicians are. And for the public, I would say the framing conversations are access. How will I be seen? When will I be seen? Is it safe for me sitting on this waiting list? How long will I be on this waiting list? Why is it taking me so long? Why does somebody not want to see me in person? I want to be seen in person. I don't want to be seen in person. I want to be seen online. Why can't I be seen online? Why isn't everything on my phone? The framing conversations of access will also impact on politicians, and that's important. So waiting lists and access will be something that will continue to come up. I think there will be other things that will come up on the doorstep during the election. I think there'll be children's mental health. When I was a chief exec in the health service, which I was up till 7 months ago now, 8 months ago, children's mental health and access to children's mental health services was something that came up again and again in my postbag from local councillors and politicians. I'll be surprised if it doesn't come up. It won't make the headlines, it never does. Autism, ADHD does, but generally it doesn't. And the other thing that will come up will be dentistry. It will continue to come up, access to dentistry. I could talk for ages about what I think we can learn from dentistry and how we could think about that in terms of other things that are going on in the health service at the moment, but dentistry will be there in a way it hasn't been before. And the other frame that I think that research and rapid evaluation takes place in at the moment is magical thinking. There is a lot of magical thinking at the moment. One of the biggest is AI will save us. Fun facts, it won't. But magical thinking is huge at the moment. The biggest of that is AI. The second of that is the long-term workforce plan will save us. We will be able to recruit, we will be able to retain, we will be able to train, and the world will be a better place. These are all the frames that are there for us as we do research. And what does that mean? It means it's noisy. It means that what we do has to be clear, and it has to be really accessible. It has to be something where the messages that you have from your research and that we have can be understood in a paragraph. I know that's hard. It means that people need to be able to pick up and understand really simply and clearly, how will this help me and how will this help me today? It needs to be a way in which we are very able to cut through noise and complexity with simple but truthful and honest outcome-based research. I think accessibility is absolutely essential. Whilst we live in times where evidence is questioned often, and we live in a world of conspiracy theories, that isn't the world of the leadership of the NHS or social care. It is a world that wants evidence, but it is a world that is so stressed, it can only access that and understand that often in a really clear and immediate form. And the noise of the world that we're working in makes that even more important.
Thank you. Thank you very much. Yeah, that's a really helpful and interesting perspective. So I'm now going to ask Arne Wolters to share his perspective. Arne's got a range of roles in the Northeast.
Thank you very much. Yes,
I'm going for accessibility and
It's very nice to be here, and I think I recognise a lot of faces, and my guess is a lot of people recognise me as well, because just over 12 months ago I was still working at the Health Foundation for over 9 years and have been involved in this conference. But I have since moved to the Northeast, and I hold two roles there. So I'm Head of Improvement Analytics within Cumbria Northumberland Tyne & Ware Foundation Trust, which is one of the largest mental health trusts in the country. But I'm also the implementation lead for NIHR's applied research collaboration in that region, which is a nice sort of perspective, I think, that where I try to straddle sort of research and practice. And I think in both roles, very keen to work with decision makers, whether that's decision makers in the trust or the wider provider collaborative, or in my role as implementation lead, working with colleagues in the integrated care system and the integrated care board. And I think they're all facing very, very similar challenges, which is trying to keep the show on the road, realistically. There's lots to do. There's very little money and little time to do it in. and everybody is focused on providing the best services they can for patients. And the sad truth is, I think there is very little time for the decision makers and policy makers to actually engage with evidence. And I think people in this room are in a position to help address some of that. Now, Thea already explained that AI is not going to save us. I've picked 3 things I wanted to unpick, and I don't think any of these individually are going to save us either, but hopefully they will help. So one thing I want to touch on is rapid evidence, and I feel like I'm preaching to the choir on that one, so that's good. I wanted to touch on de-implementation, and I'll explain what I mean by that. And I'm really interested to think about how we can provide analytical resource to health services on the ground to really move from dashboards to insights. So on rapid evidence, as I said, I feel like I'm very much preaching to the choir. I think there's a lot of pressure on the system, which you all know, both in terms of demand from patients, but also financial strain on the system. And everybody's working really hard to sort of keep the wheels turning and try to deliver the same standard of care for less money where they can. And I think what that does mean is that there's very little capacity to, first off, ask the right question, and then secondly, to actually wait for the answer. And I think that's really where rapid evidence, rapid evaluation, rapid analysis, whatever you want to call it, comes into play. And what we collectively need to think about is how we present the right information at the right time to the right people, so we're in the best possible position for them to use that to inform their decision making, which in itself probably requires a certain amount of horizon scanning as well for us to understand what the challenges will be that the systems are facing. Which sort of brings me to my second point, which I mentioned around de-implementation. I think lots of initiatives to try and improve care require systems to do more. But in order for systems to do more, there needs to be capacity to do so. So something that a lot of people ask me is, what can we do less of? So what are the things that we can stop doing without compromising patient safety, without compromising the outcomes of patients? So is there anything that we're doing currently that we could safely stop doing? And I don't think a whole lot of research is dedicated to that. I don't think it's the most exciting thing to do, but it might be essential in creating the space to allow for improvement projects to have space to flourish, really. And then finally, thinking about analytical resource on the ground to sort of really make the translation from data to insights. So if I take my own trust as an example, I joined there just over 12 months ago and sort of started talking with various teams, trying to understand the landscape, trying to understand the analytics that is happening. I've come across about 5 different teams that all do analysis, and a lot of them don't know of each other, and all of them love Power BI. There's dashboard galore, there's metrics everywhere, there's lots of mandatory reporting, and there's very little time for insight to actually draw the intelligence from the rich data sets that we do have access to. But just to put it in perspective, because you could make the case, let's hire some analysts and do that. Since after the pandemic, so mental health trusts have been given extra funding during the pandemic, that funding has dried up. As a trust, we need to lose about 1,000 members of staff. So there is a recruitment stop on all non-clinical staff, and my guess is that will be there in the foreseeable future. So really need to think about creatively about where do we get our analytical resource from, because realistically there is no space in the system at the moment for us to do that ourselves. So one of the things I do is go around and blag free resource where I can. So we work a lot with universities, whether that is PhD projects, master students that come in and provide that helpful insight to us, whether we're working with local charities that have capability to do that. And obviously we also engage with funders to secure funding that way. And that is the most direct route for us to be able to bring in some staff ourselves. But then that is often maybe not as responsive and maybe not as capable to sort of respond quickly to the local need in our system. So as I mentioned, none of these will save the world, neither will AI, but I do think if we can make headway on these 3 points, I think that would really help us, and I'd be very interested in your reflections on that. Thank you.
Thank you very much, Arda. Thank you. That's very interesting, and particularly raising that point, well, many points, but also about the need for that analytical support and resource and insights, so, which is a very good segue into introducing our next speaker, Abby Muller, who's from the Strategy Unit, which is based in the West Midlands. She's managing consultant there, and that unit, I know, is, amongst many other things, does provide that analytical expertise and those insights for all sorts of different parts of the health system. Over to you, Abby. You're very welcome.
Thank you, Judith. So, yes, I'm Abby Muller, working for the NHS Strategy Unit. Short lady syndrome as well here, so I hope you can see me. So those of you who are familiar with the Strategy Unit will know that as per unit strapline, we lead research, analysis and change from within the NHS. So that's our kind of USP. We are a multidisciplinary team, and we're currently about 70 plus people, and one of these disciplines is evaluation, and Paul Mason, who leads the evaluation team, is just there on the right. And I work within the evaluation team too, and I lead on qualitative evaluations. So our starting point in the NHS and within the evaluation team is that all our evaluations are rapid, and the pandemic actually challenged us further, so it made us think about what it means to do ultra rapid evaluations. So in the last few years, we've been reflecting and kind of articulating our approach to doing rapid and ultra-rapid evaluations in health and care settings. So we'll start some of this discussion now. Some of this already started, but in the later session, just want to shout out to my colleagues, Fraser Batty, who I think in the next morning session will be facilitating a discussion around how, in the evidence-based session, around how to how evaluators can get decision-making more embedded into that decision-making process. And then Gareth Hooper in the afternoon will talk about when the data and information is less than perfect for analysts and evaluators, how to work with that information. But back to this session, the audience will be very familiar that, and as Judith mentioned, that there are lots of R's that defined rapid evaluation. And we agree that there are 4 R's, the rapidity, the responsiveness, relevance, and rigor. And we would argue that from the strategy unit experience, they're all important, but what the critical feature is how they're flexibly applied in a health and care setting to ultimately fulfill the needs of decision makers. And to that end, we agree, and I'm going to read this because the literature describes rapid evaluation in healthcare to be a rigorous, team-based evidence generation approach that utilizes multiple data collection and analytical methods to identify operational problems, but we would extend it and say lessons learned as well, and both of these to inform decision-making quickly. So from a strategy unit point of view, the team delivering this rapid evaluators is not just limited to the evaluators themselves, and it does require lots of collaboration and partnership working with a wider range of stakeholders within that rapid learning system within which the evaluation question is embedded. And we find that this partnership is at least 3-way, and for us, in our experience, the stakeholders are the evaluators or the analysts themselves, the client, so our NHS colleagues usually, who are the commissioners of our research, and who are the decision makers who are ultimately responsible for putting the evaluation findings into practice. And they're also the participants, so the participants of the research who either are the data sources for our evaluation outputs, so the staff or the patient contributing, or they're facilitating us to receive that information. And of course, there's sometimes an overlap of roles as well. The clients may themselves be the participants, so often our client will ask us to interview themselves or their colleagues so that we've got a kind of a robust way of collecting their perspectives as well as part of a qualitative study. So what does good look like when we're working together? It means that we have transparency across all stakeholders as to what the questions the evaluation can answer, what information it can provide. It also means that evaluators, we as evaluators manage the client expectations of the evaluation from the outset. If we can't deliver something, if the evaluation is not going to answer what the client thinks it can answer, we let them know as early as possible. We build that into the logic of the evaluation. It also means that we have to build rapport and trust across the partners, and we have to sustain this throughout the evaluation. So this sometimes means that with our clients, we update them on a weekly or a fortnightly basis, and we troubleshoot together. If there's issues with engagement with the evaluation, if there's issues with sourcing data, they are aware of it. We don't wait till the end to let them know that. So we work together flexibly throughout the evaluation delivery, starting with the design, and then for the data collection and analysis, and then also for the reporting. And all three of these have equal merit in terms of delivering the evaluation. So what does that mean in practice? It means that for design, we work iteratively with the client. We start with an evaluation scoping phase. That could be a few weeks to a couple of months. And we establish the evaluation logic with them. We test these things. We establish the key lines of inquiry with them, the evaluation questions. We agree the milestones for each component of the evaluation. And then for the data collection and analysis, it often means that we have to ask the client to broker the relationship for us with the study evaluation participants. So this could mean that for a specific intervention, it's the program team, the national program team who is our client. They will know who is piloting the intervention that they want us to evaluate, or they will have a relationship with colleagues in ICSs if it's a system evaluation, and they will get in touch with them on our behalf, introduce us, and so that we can start building a relationship and design the evaluation with those. And then it also means for reporting, we agree the outputs quite early in terms of what the output is going to look like, what they want the report to look like. Is it going to be a Word document? How many pages do they want it to be? So effectively, how busy is the client? Will they actually read a report that we're going to write? Do they want it in slide format? How frequently do they want the evaluation outputs? And this part of it really comes into its own when it's a rapid evaluation. And in some cases, in terms, especially during the pandemic, our evaluations outputs our interim evaluation outputs were on a weekly basis. So we were doing field work and then coming together as an evaluation team, kind of synthesizing emerging findings and reporting to an agreed template to the client within a week. And there were kind of successive weeks of those things. I think that's about my 5 minutes worth, but I'm happy to expand on any of these things in the panel discussion and later. Thank you very much.
Thank you very much, Abby, and much for us to return to there about trying to be ultra rapid, but that very strong focus on the team-based and collaborative approach. So then I'm going to introduce our fourth and final speaker of this session, Yannis Bakoulis from the Centre for Implementation Science at King's College here in London. I think we're going to particularly focus on this getting into practice, knowledge mobilisation aspect. Over to you, Yannis, for your contribution.
Thank you very much. I'm delighted to be here and see such a great audience. So I'm based at the Centre for Implementation Science. I am the methodology lead at the Centre for Implementation Science, and also the Economic and Biostatistics co-lead on the NIHR Applied Research Collaboration in South London. So our centre, for those who don't know it, it has a kind of a wide portfolio of different research projects which are spanning from clinical and implementation trials. So we're working on the full spectrum from clinical trials to pure implementation trials and all the hybrid in between. But also we're interested as well of how we could do service evaluations, and especially this fall within the realms of today's topic, rapid evaluation within services, but also how we can do rapid evaluation in terms of national policies. So I thought that today it would be nice to share like two successful examples of our center, which leads a little bit within how we can do rapid evaluation with the other 3 R's, which will be relevant, rigorous, and responsive. So the first example I would like to share was like during the COVID-19 pandemic. So when COVID came into place and the lockdown measurements, what we wanted to do, as a lot of other people within the UK and globally, we wanted to rapidly evaluate the impact of lockdown measures on mental health services, how the services will be reconfigured. Even we're talking about child and adolescents mental health services to old age psychiatry services. But also we wanted to look at the mortality of service users as well as the forthcoming admissions that we have within the services. So alongside as well, we had like kind of a electronic mental health records data infrastructure that could actually help us within and addressing these questions within the rapid evaluation. But I think what was successful with the project as well, and this leads more to implementation, to knowledge mobilization, was the fact that along the side we were working on sub-projects around developing a survey, but also some qualitative interviews with service users in regards of how acceptable they will find potential vaccine implementation within the UK, and also working very closely with Public Health England as well, sharing our results, because we had the capabilities based on the data infrastructure to monitor as well as providing results in real time. And this, I mean, like alongside our research that we did within that, and working with grassroots communities to look at ethnic inequalities as well, we managed our research alongside other research was influential in changing national strategy priorities in terms of prioritizing people with severe mental illness when the vaccine rollout happened. And one of the issues is like that's one way of how we can be responsive, like when there's not a policy into place, how we can start from the beginning, how we can have evaluation not only of the effectiveness, not only on the impact, but also on the implementation factors that will lead to when we want to scale up or when we want to influence policy. And that's one way of how we can be reactive on something that happens at the moment and how we can influence policy. And the second example I would like to share was during a service evaluation and implementation of integrating physical and mental health care systems within the South London and Maudsley Hospital. So it was more like kind of a service evaluation which was run through our trust, but and it was part of the Body and Mind program as well, and something that we knew that this would lead to a kind of a wider scale up nationally, but also internationally. And within that service evaluation, this was already a policy, already a service that was already offered within SLAM, within the South London and Maudsley. It was a service that will help people with severe mental illness to manage better the physical healthcare in order to address the gap in relation to the less life expectancy that people with severe mental illness have compared to the average population. But also what we were interested in as well is like to use some behavioral science techniques as well and some implementation strategies to actually intervene within the rollout of the service. So we were monitoring the process, but as well on the same side, we were trying to influence the process. We're trying to use different implementation strategies and see if they work in real time. And also as part of that was a lot of engagements within the clinicians and how we can improve the capacity of clinicians of actually accessing relevant material when they had to refer people with service users to more kind of physical healthcare settings, how we can integrate a physical healthcare team within the mental health teams, but as well working as well with service users of how we can develop online tools, how acceptable will be the service of that, how appropriate, implementable. If we were scaling up, we had enough information to provide to the next stage. So I'm using these examples because they have a core element, and I think they were successful because obviously we don't have always successful stories. Usually we don't have successful stories. In general, was that we have the core aspect of that is that implementation was as part of from the beginning and alongside what we were trying to look when we were evaluating the policy. And also, as well, we are very good on building data infrastructures, and we have fantastic resources around looking at health metrics and evaluating the effectiveness of the policy and the program. However, still, we're not good enough to build implementation metrics around that. And this, if we want to move forward in rapid evaluation, especially in tight budgets, we need somehow the health system to collect more rapidly and build data infrastructure and methodologies around how we can do those things alongside. Thank you very much.
Thank you so much, Yanis. Thank you. That was fantastic. Thank you. So we've heard from all four colleagues. Just to distill certainly what I've heard from each of their contributions, as you're hopefully developing your questions, ready to share them very shortly. I think Thea really made the point about this need for evidence in tough times, but the evidence to be heard, and also about focusing on where the public come from. That was something I really took from what you said, Thea, about thinking about access, safety, and so forth. But also, I think for those of us who are evidence producers in the room, your point about accessible in a paragraph. It's a very powerful point, and cutting through the noise and complexity, you said. And Anna, I think you picked up on some of those points as well, but you talked about asking the right questions and waiting for the answers, but I guess not waiting too long. But I'm really interested about that point about de-implementation, that finding evidence about what not to do or what we should do less of, rather than more and more and more, isn't it? You know, so I think that's a really important challenge. And the point I think I highlighted earlier, the one about analysts and analytical resource, and them as people and as a profession, I think was a point. Abby, the term ultra rapid evaluation, there's a sense we can, it's like the Olympics, isn't it? Higher, further, quicker, or whatever. So, but I think a strong point you were making throughout was this working with clients, but the scoping, the management of expectations, trusts, but a deeply participative process, and quite an intense one for the way that we have to, all parties work, whether service users, analysts, policymakers, managers, practitioners. And Yanis, I think again you drew it together really nicely with those very powerful examples that I think, and again I got a strong sense of that working with, for example, Public Health England, but constantly iterating and not only doing the evaluation of the mental health services during lockdown, and then about the combined physical and mental health needs of people in South London, but that sense as well of always having the eye to what we're going to do with this, working with people about that. But, and again, such a powerful point about developing implementation measures and working on those from the outset and then actually using them. So that's something about what I've heard, and I don't know about you, but I've been really struck by those. I think there's a strong theme of collaborative working and partnership through what all four colleagues have said, but also, unsurprisingly, being fleet of foot. But also, I think there was a sense of rigour being needed as well, that the evidence is usable, believable, and as robust as possible. But that sense of it always, in a sense, on the move, the job is sort of never done. So that's what I've heard about from what our colleagues have said about rapid evaluation in these really tough and challenging times for health and social care services. Over to you now. Do you want to, if you've got questions, what we'll do, well, perhaps I'll take at least 2 or 3 questions first and then sort of put them in themes back to members of the panel, and we'll keep iterating in that way. I think we've got some roving mics from our Nuffield Trust colleagues. So shall we, do you want to, I think we're going to use the time-honoured way of putting your hand up to indicate you're going to ask a question. Now this is going to be quite a challenge because it's a big room. So one there, and then just to flag to Nuffield colleagues, there's someone on the front table here to come to next. Is there another one to go to? So I've got a third for after that that they can be aware of. Yeah, we've got one in the middle. Okay. So if you can just briefly say your name and where you're from and make your point.
Hi Judith, it's Caroline Nicholson. I'm actually from Australia, from Brisbane, but the themes are, I have to say, 100% very similar to the issues that we're all facing. I think there's one comment and then one question. Just in the front of the book, I think it says, you know, how do we do more with less? I think we need to change the rhetoric and say, how do we do differently with less? Because I think we've all got a workforce issue, you know, from what I've heard in the last few weeks of being here. So I think we just need to allow people and give people permission to think about doing things differently. I think everyone's very stressed and overwhelmed, so I think it's really important that as clinicians we feel that we can do that. I think the question particularly comes to Ionis's comments and Anne's bit about, I was talking to people from Gloucester just last week, and they've done some great work. They're clinicians, they're in primary care and the acute care sector. They've gone ahead and done something because they saw the need for it, and then they said, oh, we're doing the evaluation next. And then, well, how's that going to impact policy? Well, we'll think about that next. Somehow or other, I think, how do we put evaluation within the system and give people access to that, even when they're thinking of these bright ideas? Because as clinicians, we're very reactive. We would tend to do first and see if it works. And we don't always evaluate or think of evaluation as, the evaluation will help you see what the outcome is you're trying to measure, rather than think about it down the track. And so I think my question would be, we can do rapid, but I think we have to be there as evaluators right at the very beginning when people are having the bright ideas, and how do we do that?
Thank you very much, Caroline, and yes, good to have you with us from so far away. I think Fraser here at the front, I think was the next one.
I think there's a mic in the middle already.
Oh right, sorry, we'll go to the middle one first, if that's who's got the microphone, whose name I don't.
Hello, Jan van der Scheer. I work at this institute at the University of Cambridge. Thank you very much.
So I do know you. Sorry, hello. It's so nice to see you.
Good morning, Judith.
A lot of faces.
You didn't see my height because I wasn't standing up, of course, which is a defining factor. Among the many questions that could be asked, and I thought it was an extremely insightful first panel session, one to Dr. Bakolis. You mentioned the challenges with good implementation metrics. Perhaps you could say a little bit more about what are those challenges and why it's difficult to produce good ones, and perhaps a few examples of ones that have been developed and that are now working well and that we can perhaps build on.
Thank you. Yeah, we'll come back to that in just a moment. Yavis? They're giving you a microphone, Fraser? They have.
They have. Here it is. Fraser from the Strategy. It's a question for Thea, really, about your touching on the importance of productivity in the policy conversation. And I guess what I would see is a sort of overwhelming drift towards the magical thinking that you're describing. I loved your use of that theme or that concept. Because we've got the promises of tech, we've got a very heavily capitalised sector that's leading towards that. We've got a desire to believe, we've got a bias towards novelty. So you can completely see how magical thinking results. I guess my question is semi-pessimistic, but I'm encouraging you to push back. Is the evaluation world sufficiently powered to help rebalance that magical thinking? How do we not just go along with that drift?
Okay. Perhaps first of all, they're fantastic points and questions. Abby, can I turn to you and just ask you to respond to Caroline's point about how do we, perhaps if you can use examples of how you see this happen, have this evaluation that in a sense built in from the outset, so we're not sort of constantly chasing after the fact. Have you got thoughts about that?
A great question. So I think what we're seeing in the NHS is that from a national level, so where it's policy adoption or where there is national rollout of interventions, we are seeing that evaluation built in. So we do get commissioned, we do start having the conversations very early on with NHS England, usually as our client, to kind of start thinking about the evaluation and to help them with their thinking in terms of the design of the intervention as well, and how we're going to measure kind of the outcomes of that. Where there are weaknesses is as you already suggested, is more at the front line, where a service change is happening. And there people might not have access, or it's not their usual way of thinking in terms of doing a system change and thinking about, you know, what might be necessary. So I think what we need to do as evaluators is you know, and especially within academic settings, is to make that resource available, to promote that resource, to say that there is evaluation capacity, capability, and we can meet the needs of frontline practitioners to be able to do some of that evaluation activity. So at the moment, it relies on people knowing us or having heard of us, or in terms of the NHS Strategy Unit, to do some of that evaluation activity. But yes, there's definitely more that we can do to promote evaluation activities more.
So that's really interesting, that point that often that evaluation resource might be more likely to be there at that policymaker level than at the front line. Arne, you're working more with people in trusts and integrated care systems kind of at the front line. Your thoughts about that point, that challenge that was made?
Yeah, so first of all, I want to acknowledge I completely agree with you, and I think it's essential to have that evaluation early on, because particularly if you do stumble on something that does work, I think the benefit that the evaluation brings is also to have implementation learning alongside. So if you don't want to adopt and spread, you have that learning from the get-go, and you don't have to sort of restart pilots in different places. I think in terms of how to access that, it probably really depends on where you operate within a system. So within our trust, we're quite a big trust, we're quite a big sort of research-driven trust. And so within our R&D team, there is support for clinicians who want to try something out, to sort of engage with us very early on in that innovation pathway and get some support along the way. I think if you're a clinician working in a GP practice in a rural part of Cumbria, I think you'll struggle a lot more to get access to that type of support. So I think in the end it will really depend sort of where you're based, and maybe as a system we can think about, particularly for people who are sort of working in much smaller settings, how they can best access that evaluation support.
And do you see, have you had experience of integrated care systems helping with that? Because it would seem to me that might be a way of offering some of that evaluative support and capacity to, for example, general practice or community services.
Yeah, so I think there's examples where that's working really well. So there's a number of practices within primary care networks within the Northeast that come together, what they call the deep end practices, and where they've sort of built up that network between them, and where they can get that support, and that's certainly made easier with more collaborative working in the region. But it's not something that's available to everyone yet.
Okay, let's hold that one. I think there are some primary care colleagues in the audience may want to come into the discussion in a wee while, so that's interesting, thinking about the primary care networks aspects of this as well. Thea, magical thinking. You weren't going to get away with having said that one, were you? But,
absolutely not, and it's a great question. And so you've given me 2 minutes to think about it, which is even kinder of you. I think it goes back actually to what your colleague said, which is about participation, collaboration, and who's in a room. You asked me, is this sector powerful enough or powered up enough to sort of, as it were, that classic question, to speak truth to power about magical thinking? I think it probably is, but it's whether or not anybody wants to listen. So is it powered up enough, and will it be asked to do the right research, and will it be asked to consider the right question, and will you be allowed to frame the questions and the research in a way to truly look at the wonders of AI and also the challenges and the problems, etc. All of that is possible, but you have such a febrile environment looking for magic. I think that's really problematic. So I think where you're situated within really strong partnerships, collaboration, able to be in the room and to talk about it in a highly sophisticated way to somebody who wants to listen, if, yeah, it's great. But I think the challenge is, as we all know, probably we've all got parts of it in our lives where we really want the answer to be A, It's incredibly hard when somebody comes into the room and says it's a little bit A, but it's looking quite B. So yes, ish.
That feels like that summed up evaluation practice.
It's yes-ish. Yeah.
Okay, Yanis, you've had 3 minutes to think about it. Do you want to just respond to that point about that Neil raised about implementation metrics? Just tell us a bit more about both some of the challenges of those and perhaps examples of where you've seen it work or start to work.
Absolutely. So, thank you very much. That's a brilliant question. It's like something that it's challenged me as well through my everyday work. So, I think there are 2 different types of implementation metrics that we can see, and this is more or less depending mainly on the funding structure that you will have. So, for example, you can run a clinical trial. You have the funding to do that. It's very well. You know, like you have well-resourced staff, and then alongside within the clinical trial, you can have like kind of start looking at more like implementation. This could be as part of more like a mixed methods types of research, so you can look at qualitative interviews and so on to understand how this is working for the different stakeholders. But then there's the quantitative element that you want to evaluate within this, and this it could be, you know, like within the Proctor paper of the 7 domains of implementation, then because you have the funding, resource, and the capacity and all the stuff there, you can see you can see the readiness of change of the organization. You can look at some more system level variables. There are some measurement tools such as like appropriateness, feasibility, acceptability that they're existing there with some good measurement properties. And you can do a proper kind of evaluation of effectiveness of psychosocial intervention, but as well as you have some metrics alongside that. But that's great because you have the resources to do that. And usually what happens with these metrics within a trial, because you have a lot of resources, people usually would like the trial, will find it accessible, feasible, and you won't get much variation about how much implementation actually affect how much implementation affect your clinical outcome within the randomization process. And that's one way that you can develop the metrics, and this is one way we do it. But when things get really problematic is that when you're using with this kind of service evaluations, and this is where you can have some system level metrics, you know, you can see if there's an adoption based on particular definitions, but we are not alongside, I mean, like the system is not somehow routinely collected. Let's say implementation metrics about how patients are find acceptable or feasible or appropriate in the service, what is the cost, and how this can be embedded as we do in real-time monitoring of a process, how we can have a real-time monitoring of the implementation process alongside in a quantitative aspect. And this is lacking, and I think is lacking for 2 reasons, because the field of implementation science is fairly new, although we are all talking about it. And the second reason is that the capacity of people working within that, and this is not the capacity only for the analyst perspective or the policy perspective or the service user perspective, but is the capacity of people thinking that when they're, as we just link it with the previous question around something that is already happening on the system, not have to, you know, find somebody to do the qualitative interviews, to analyze it, transcribe it, try to implement some metrics, because then, you know, like you lose all this rapid type of course of action, and that's important. So there are metrics, but I think they are not good enough, and they are not embedded routinely on the system.
Thank you. And have any of the others of you had experience of almost, it's going through my mind, almost like the implementation measures that you leave with the service as perhaps the evaluators depart or at least depart for a while? I don't know, Abby or Anna or indeed Thea, you know, either whether you've done it as evaluators or users, have you had that experience?
So, did you want to
After you.
No, so I think what we've seen most successful across ARCs is sort of where there's like clear implementation toolkits that sort of go through what can and can't be done. I don't know if they're necessarily metrics. I think what's fundamental in my view is when we talk about adoption and spread is that we think about adaption and sort of build that in as part of sort of developing an innovation. In a way, everybody thinks they're special. So when somebody tries to solve their own solution, they try to start with their own, if they try to tackle their problem, they try to start with their own solution and don't necessarily look elsewhere. So I think if we think about the adaptability of things that we're implementing and really sort of sell that aspect, that would make it easier for people to then sort of take up a solution from elsewhere.
So it's back to your point, Abby, isn't it, about this working from the outset with those who will use them. Just to flag as well, I'm always a bit sceptical about toolkits and whether people actually use them in the service. I'll come to you about that in a moment, Thea. I think there is quite a good academic paper actually showing that the answer to that is not used very much. But Abby, your thoughts about this, about implementation measures, and at what point do you leave them?
So we tend to, from the beginning, from the outset, work with them to develop a logic model of their kind of intervention, and that works really well for our NHS practitioners because it's akin to what our NHS colleagues used to do a few years ago in terms of a plan on a page. So the evaluation kind of logic model also almost gives them the activities, the implementation activities that they need to do, and then helps. They are kind of co-producers of that logic model, so they will then say, okay, these are our kind of short-term outcomes. If we are able to do the activities, if the implementation fidelity is there, then we can achieve these short-term outcomes, and we'll have that two-way conversation with them. So where we would leave them, if it is a true rapid evaluation, if it's not cycles of rapid evaluation, if it's cycles, we can work with them to kind of think about what would be your medium-term outcomes. And then we're very clear that we're not here to do, unless they've commissioned us, and it's a 5-year evaluation, for example, that we can't really do the impact bits, but these are our recommendations on how you might do them. So the metrics, if it's a mixed method study, we might help them define what those quantitative metrics can be, but we are largely working on those process aspects of it. So yeah.
Because leaving that a clear set of, I guess, relatively easy to collect metrics could be a real gift to a service, couldn't it? Or indeed to policymakers as a result of the sort of work that all of you've been describing. Having been a lot of the time on the receiving end of this sort of work, particularly in your NHS and other experience as a manager there, what are your thoughts about that?
Yeah, I hate toolkits. I've never found a toolkit that I liked, but I've also come to the conclusion that there's probably a personality bit of research you could do around who loves and who doesn't love them. Because I would say that I always had staff who loved a toolkit, and there were always people like me who never read the detail. You know, I'm somebody who will always try and put a piece of furniture together and not read the instructions, and then it will go wrong. So, you know, I am disposed not to like toolkits. It's probably a personality trait. But there are staff who really do like toolkits, and they want to follow them and they want to use them. So I don't think there's probably a categorical answer around it. I do think that implementation and the focus of implementation is incredibly important, and implementation always takes 3 times as long as you think it will. I love the way you described it as adapting as you go, because spread and shift, as we all know in this room, doesn't work. But adapting, I think, is a really lovely way of framing what you're doing and learning as you're going, and then adapting, I think, is incredibly important. And where you've got people on board with the right metrics around implementation, the right metrics that you're gathering, most NHS staff, in my experience, and social care staff get really enthused by it. They want to see it. They like to see that development. If it's really meaningful, it's been done properly. And they also know that other people are looking, by which I mean the most senior part of your organisation are caring, are looking, are interacting with it, then it will have an energy that keeps going with it. So I think the right metrics, seen by the right people, owned by everybody, and the recognition that implementation is never simple and never quick, helps frame all of it.
Thank you. Thank you to all of you. Excellent reflections and really, really helpful. Let's move on and take some more questions from the floor. There's a colleague in the middle, and then one on the table just in front. And then Sarah at the back on the left. I'll take those 3 next. Yes, over to you.
Hi, so Lucy Sandell from NHS England. There are lots of individual examples of good practice, but there's still no agreed national strategic approach to evaluation. So how can we build consensus to make evaluation a normal business as usual part of change?
Wow, thank you. We'll come to that in a moment. We'll get thinking. Thank you. Excellent question. And yes.
Hi, I'm Alex Humphrey. I work in Bristol as part of an evaluation team, and I've got a question for Thea. You're talking about cutting through the noise and the complexity with something in a paragraph which is simple, but also I think you said it needs to be simple but honest and truthful. I think that's really hard. I'm thinking about, you know, AI will save us. That's nice and simple and cuts through, but is not necessarily honest or truthful. And then you're responding to this gentleman at the front about an outcome evaluation being mostly A or a little bit B. That's not so simple. People don't like that. So just if you could give an example of one or two simple but honest, truthful things. Thank you.
I think you've had your bluff called there.
No.
No. Okay, thank you for that. And, oh yes, we've got a microphone there. Back.
Brilliant. My name's Sarah Shaw. I'm from the University of Oxford, and I lead DECIDE, which is the Rapid Evaluation Centre focused on a bit of technology-enabled remote monitoring. Thank you so much for a really interesting discussion. I'm really interested in the idea of mega rapid evaluation, which I find a bit scary. And so my question is, how rapid can rapid evaluation be, and what are the trade-offs that we need to make that happen, and is it worth it?
Thank you, Sarah. Excellent question. So concise, I'm struggling to write it down. Have we got another one here that you're wanting to take? Yes.
Hi, I'm Tasneem Marine Iqbal. I'm from NHS England as well, working in urgent emergency care policy development. And I was just wondering, in the context of rapid evaluation, how can we move away from what we can know, so what is easily collectible and understood, to what we should and ought to know?
That's excellent. I was thinking about that for an essay question at the university. It's so precisely put. Thank you. Okay. Actually, I'm just, Thea, going to take that first one about some examples of your simple, honest paragraphs.
Well, I think all
evidence.
of you write simple, honest paragraphs when you write an abstract for your research.
That's a good point.
So I was thinking, you know, can I sum up virtual wards? Can I sum up remote by default? Can I sum up PIFU? Things that, you know, my colleagues have done. I probably could give you a sentence. And then I thought, you all can. I think what panics us all is often when we give those sentences or we do that abstract, we also all know in the room that there are many other things we want to say. There are many other caveats that we want to give. There are many other but statements that we know, and you in particular know as excellent researchers, that you want to put forward. But everybody in this room, because it's a very eminent audience, has the experience of writing that abstract. And that often is a paragraph, and has the experience of explaining what, you know, say, tell somebody in a lift, what is it between two floors that you found about virtual wards? And we all know that when you get off at the next floor, you want to say, but I also wanted to tell you this. And I know that, and I get that, but somehow we have to cut through with, this is the core message. You know, the core message, remote by default. We did an event together in Parliament a few weeks ago. It was a brilliant event. There's a lot of complexity in that research, but there are some key messages, and that we can keep giving. And I think it is a complex ask for the research community, because your depth, your experience, your knowledge, the way in which you know all the complexity of that world is really challenging then to come through with that abstract, and when you get off the lift, not go, but by the way, I also want to tell you about these things. But I think you actually all have those skills and you use them all the time. And we have to accept that we have to think even more carefully about that abstract, about those 3 points, because it is what people will engage in this very complicated world.
I think that's so interesting, and I guess there's a number of people in the audience who, like me, often leave the abstract to the last thing you do. Now, that's partly you can argue you need to have done all the work before you do it, but I think if we're honest, it's because it's often the hardest thing to do.
It's very hard.
Just as I remember when I was a director of a centre at the university, trying to get some of the academics to write a concise blog. It's almost like, it's a sacrilege to have to distill your work to that, but it's the toughest but the most important role, isn't it? Arne?
Yeah, and I was just going to quickly say I completely agree with you, and I think what really doesn't instill confidence in the policymaker to act on your evidence is a list of all the additional research that needs to be done before you're sure. So I think next time you write something with a policy audience, just leave that bit out, I think.
And actually, colleagues, you may well be aware of it, but Chris Whitty, the CMO, wrote a paper a few years ago in the BMJ about evidence for policy. And if I've got it right, what he said, it was almost like it was better to have an 80% right, as it were, sort of a piece of research, as long as it's been rigorously undertaken, that's on time, than to wait a while for the sort of 95-100% that's going to be just too late when the decision point has passed. So I commend that paper to you if you haven't seen that one. I'm going to move us now just within these themes here, actually, and it's sort of sticking with, well, no, that was the one about, I guess, focusing evidence and being obviously truthful within that about what it says, but also perhaps what it can't say. Abby, do you want to respond to that challenge about that Sarah was making about the ultra, or she said mega rapid evaluation? And I think her questions were how, what trade-offs, and is it worth it?
Great question, and I have to give an example from within the pandemic kind of evaluation work that we did. So it's how and is it worth it? It's worth it because the decision makers. So the challenges comes from the client. It was an NHS England commission. There was I'm probably not allowed to say in public which intervention it was, but we were all recipients of it, so you might guess. So, and that evaluation, that process evaluation needed to be delivered in a timely way because decision making on a weekly basis of how the intervention should be delivered was happening. So it was worth it because the client was able to make iterative changes to their program as the intervention was being delivered. So those weekly reports that went to NHS England and to the DH ultimately were helpful. Was it worth it in terms of the overall report that we did a few months later? So we did a rapid evaluation, but within that we did ultra-rapid reporting. So the reports was still quite accelerated from a kind of evaluation perspective, the final reporting. The challenge then was that the recipients of the evaluation had moved on the accountability, the ownership, because that program ended. And so there was no one there to receive it. And then when you have a very clear-cut finding, but it is more, mainly A, but a little bit of B, and the little bit of B is very political. It just doesn't get, it can't be taken up, it can't be published, it can't be, because there's some sensitivities around that. So that is a shame. So from an evaluator perspective, especially as embedded NHS evaluators, it's very difficult. It's difficult for the team as well because you've worked in this very accelerated, adrenaline-fueled way to deliver an intervention, an evaluation mapped to a national need, but the take-up of it is not as great as you would have hoped.
I guess, Abby, just drawing on other experience I've had and I know colleagues have in that sort of situation, sometimes you can't perhaps get that message out there at the time, but actually where we know that academic publishing can grind slow, slowly, and that can be a problem. But sometimes that can be an opportunity, that when things have moved on, there is an opportunity to put that out there into the academic literature, isn't there, to almost sort of stand the longer test of time and build that broader evidence base. It's just a thought about...
So there's some of that, but also some of the more kind of nuance or the findings within the evaluation. So now at the moment we've been commissioned to do a national evaluation of healthcare inequalities programme. Some of you will be familiar with the Core 20+5 approach. But within the pandemic, we learned a lot of lessons around how to deliver interventions to the public, and so some of those lessons will have continuation. We're the same evaluation team. We've learned a lot. The NHS England nationally have learned a lot. So actually, how do we utilise some of those evidence pieces in a different evaluation as well? So that's also fair.
And Yanis is nodding. I guess similar experience for you with those programmes, likewise pandemic related.
Yeah, absolutely. I mean, like I wanted to touch upon about the ultra rapid evaluation, and I think what is the key here is how rigorous is that as well. So I think. The thing is that what happened with COVID, I mean, with all the with interventions that were run through COVID, most of them, COVID was a kind of a natural experiment. If we say that we have huge compliance around it. So a lot of the research that could happen because there was this kind of natural experiment happen, and that was one of the things that, you know, like methodologists like myself like to work with. And the other thing that happened is that all these kinds of barriers that you have regarding data access or actually talking, that was kind of lifted. And you had like a kind of ultra-rapid response, at least from the academic strategy policy side. I'm not sure how much from the political side. So I think the key to this ultra-rapid evaluation, what is the trade-off between doing something rigorous with doing something that is actually has impact and makes sense? And it's not only about the ultra-rapid evaluation, but any kind of service evaluation you do, because I think the importance of that is to adapting, is to implement better interventions, to work within the system. And sometimes the trade-off of doing that is larger than actually be very rigorous on this is a proper evaluation, this is a proper monitoring process, and so on.
That's a really important point to hold on to for some of the discussions, perhaps during the whole of today's programme, about sometimes it sort of links to that, the national point I'm going to come to in a moment, but how much does the system enable that sort of work to be done, whether it's, as you said, data permissions, ethics. They're kind of really important things for evaluators, but they can actually get in the way of being even vaguely rapid sometimes, let alone ultra rapid. Thea, I think you wanted to come in.
I think really builds on your point, because I think when you're into the world of ultra rapid evaluation, I think you're into improvement methodology. And I wonder if that partly links to your question about national embedding of evaluation. I think there is a link to the embedding of improvement methodology, which sometimes has a wider uptake and wider acceptability. And I was reflecting as I was listening, probably the most exciting ultra-rapid evaluation was, I ran the vaccination centres for Leeds during COVID. And when we established these very large vaccination centres, the really big ones, we had an embedded improvement team that works alongside us. You could call that rapid evaluation. We called it improvement. And I'd never worked in that way before, in that we, every single day, every 24 hours, we checked in with our improvement team who was working across the whole system, and every single day we changed things. And it was extraordinary, because every day we'd hear the queue doesn't work in this way. This is the reason the queue doesn't work. This is what's happening with the cleaning between patients. And every day we change things. Now, that you could call that ultra fast evaluation. It wasn't. It was improvement methodology. It was a Virginia Mason trained improvement team who were embedded alongside us who did the vaccination. And the reason it also worked was everybody listened to what they said, and everybody did what they were told to do, because we were in an extraordinary bubble. But it was ultra quick.
Very interesting. I think we're all continuing to learn the lessons, or perhaps need to continue to learn perhaps more from that experience of the pandemic, the way we worked in all sorts of different ways.
For sure.
Now, we've got a few moments left. I'm going to take the 2 points together. I'm going to ask each of you just to briefly comment on this one. There's this point about could we move from almost like what we can collect, the kind of, in one sense, quite a pragmatic approach, I guess, isn't it, in evaluation, but to what we should be finding out and learning. And wrapped within that is that question about, do we need a national strategic approach? And if so, how? I mean, I've sort of, I guess, nudged at the sort of, there are some things to do to help clear the way sometime, but two, I think they are related points. I don't know who wants to go first. I'll ask each of you just to make a few comments about it. Arna, you've made the mistake of nodding your head.
Yeah, I realised that as I looked to my right.
School, I think you need to look away, isn't it?
So I think there's two things I want to say. So I think we are moving away to some extent. I think BPIE, which was relatively new.
Patient and public.
Yeah, patient and public involvement and engagement, which, I don't know, 10 years ago wasn't something I did in any of the studies I was doing, and now it's very widespread, very common, and I think there's some really, really good practice out there. And I think that has really helped think about what actually matters to patients rather than what happens to have been collected in administrative records that we happen to access for research purposes. That doesn't mean we necessarily have quantitative metrics available on those things, but I think it does mean that a lot of the work, analysis and evaluation that's happening by anyone in this room is on things that matter to patients more than they were previously. And I think, and correct me if I'm wrong, I think some of the funders will essentially have an expectation that a percentage of your funding is spent on that type of activity. And I think bridging to how do we then embed evaluation in improvement plans, I think we need to get to a similar position where the expectation is, if you run an improvement program, that a certain amount of your investment, if you like, of your new initiative is something that ought to be dedicated towards evaluation, or at least understanding the impact that the change is making. And the only other thing I did want to sort of briefly touch on in terms of metrics and changing and measuring what matters, I think there's also a lot to be done still with the information we are collecting, particularly if you think about linking up data within systems. Within our trust, we did a piece of work to try to understand better what's happening to our patients when they die. And we have no idea, because we don't know when they go to an acute hospital. We don't know when they go to the GP. We don't really know what the cause of death is unless they die in our own hospital. Even if we transfer somebody out to an acute hospital, we don't know what happens after that. And then I think a lot is changing at the moment with federated data platforms, subnational secure data environments, empowering integrated care systems to get better at that. So I think there's some work to be done with our current metrics as well.
Thank you. No, really good point, because the NHS is so hugely data rich. Abby?
Yep, so I can pick up on Arnie's point in terms of the data collection and using some of that data. So I think we collect a lot of data within the NHS, and I think it's underutilized. And especially when it comes to involving, when we talk about kind of participants and who are we, what data are we looking at. So if from a healthcare inequalities point of view, Thea's point earlier around access, that point I agree, that point around access is going to get more and more critical, but who gets access, and where is access equitable, and where we have the data on, for example, socio-economic deprivation, what are we doing with that data around equity? How can we use our evaluation analytical approaches? How do we be creative with those approaches to better use the data? We, within the strategy unit, have a new data science team. One of them is looking at how to use the Friends and Family Test, for example, and the qualitative data within the Friends and Family Test to have a look at the difference between access in terms of ethnicity, for example. So there's a lot more we can do with the data that we already collect.
So sort of working with what we've got, but extending it and mining it and thinking perhaps
more creative,
more sophisticated or nuanced way about it. Thoughts from you, Yanis, about these almost like what we should more than what we could? Got that right?
Yes, I think, tapping into a little bit about if we need a national strategy question as well. I think in terms, if we're talking academic environments, there is X number of frameworks, there is a framework, for example, how to evaluate complex interventions. They are heavily cited, heavily being implemented. There's the same, there are a lot of implementation science frameworks. Patient and public involvement is a big topic nowadays. There is a great moving of funding and infrastructure, of embedding based in the public involvement within the research practices as well, and to influence policy. So I think we have all this information. Probably what we are lacking probably is the communication of how we can do that at the national level. At a certain extent, there's great efforts, I mean, like as we discussed around, even from data infrastructure, of how you implement data policies. And I think I wanted to touch something about, we're talking about evaluating intervention implementation and doing things, but we didn't discuss about de-implementing things. So I think there needs definitely to be a strategy or a framework about how to de-implement things, because what we found very difficult when all these are in place and services roll out, and the clinicians like it, the commissioners like it, but at the end, when you start evaluating, you don't see something that is what you're expected. Then the problem is like what you do. How do you convince people to stop doing it if they're doing it? And I think that's the whole spectrum that we need to think, not only about evaluation from all the phases, from pure effectiveness to implementation, but also to de-implementation as well.
Thank you. No, and I think it's an important point about this. It's a national strategy, but a lot of those frameworks are there, aren't they? But there's something, perhaps a challenge for the academic community to work more closely sometimes with the policy community to draw those together. Thea, perhaps a final word to you to draw together the thinking in this area.
Yeah, I'm not sure a national strategy will help, because I'm not sure national strategies do. But I do think that there needs to be it's sort of a national vocabulary, a conversation, a use of words, the ability to be in any room and say evidence matters. This is important. I was a very nerdy chief exec, which is probably why I've ended up now running a think tank. And I always thought that evidence mattered and that it was important to go, that's a really interesting idea to implement. Do we have any evidence that that would be useful? And that's actually not part of the general discourse. And I think there's something that we can all do to make a vocabulary that matters nationally, that makes it important, but keeps up with the pace, the need for change, the conversations that are happening. So you're bringing that evidence to bear on disinvestment, which is incredibly important. But I would absolutely finally endorse the fact there's so much data out there and we just don't use it.
Thank you. Well, we're out of time in terms of our resource for this session, but just to very much thank our four speakers for their contributions, to you for your questions, and for the, I think, excellent discussion we've had. And just to flag, I think you'll be able to explore many of these throughout the day, the vital importance of working with patients and the public and service users, understanding productivity in relation to rapid evaluation, embedding evaluation evidence into improvement programs and implementation, the real importance of inequalities, and indeed the point you just made there, and in fact all of you've made in different ways, of what more we can do with the data that's there, but how evaluators, and my very final point, I think is one I drew out from your contributions earlier, this importance of really effective partnership and collaborative working. This is lots of different people within this world of evaluation, but even more importantly within the world of the tough world of running and delivering health and care services at the moment. Because as you've just said, evidence really does matter. So let's thank all of the speakers. And I think it's now time for a coffee break. Is that right? I'm getting nods. Yes.